So it's a great pleasure to welcome Nicola. It's not really a welcome for her because she's been an active participant in many of the sessions that we've had thus far. And she's actually contributed some of the best questions I think that we've had sent in. It's extremely important to have some insight into this particular topic, because I certainly, in my case, if you ask me questions about the kind of immunopathology, lung disease is actually the place where people ask most questions and are most uncertain about. So I'm very pleased that you're able to explain to us insight into what you feel is going on clinically, and of course what's going on with the patients with lung disease who actually also need to be treated. So Nicola.
Well, I'm very grateful to be asked to speak today, so thank you for that. And I just wanted to make clear that I haven't been directly involved with treating acute COVID patients, so I won't be really talking about that much, just a little bit about what I've picked up from what has been going on in my hospital, which is the Whittington. So I'll summarise a little bit about how our respiratory service had to cope with some of the changes. Then just speak about a few issues generally relating to COVID and respiratory treatments and other conditions. And then move on a little bit to talk about the COVID clinic that has been set up at the Whittington. And then hopefully a little bit about COVID-related pulmonary fibrosis. But I also am not an expert on immunopathology of the lung, so I've only got a few slides to share. So back in March, my 12-year-old daughter showed me this slide, which had been shared by her friends. And if you look particularly in the first paragraph, it's telling you that by the time you're ill enough to go to hospital with COVID-19, you might have 50% lung fibrosis. So what you should be doing every day is take a deep breath and hold it for 10 seconds. And if you can do that, everything's fine. So having discussed with her where to check your sources from, and also explain about a little bit about lung fibrosis, like many medical students, she'd had enough knowing about fibrosis and went off somewhere else. But I then had this slide sent to me on 2 or 3 separate WhatsApp groups from adults saying, oh, is this right? Is this what we should all be doing? So there was so much being shared in the early stages, both medical as well as all the myths. And it just made, I think it's just such a huge change to our lives, both working and social. So in the Whittington, we started preparing in February. I think that's when we were starting to have the first meetings about what to expect in terms of testing, PPE, and little bits about treatment. And I think the messages we were getting on PPE sort of changed almost every 2 weeks. Initially, we were being told you're going to be having heavy duty PPE, isolating your patients. Then 2 or 3 weeks later, we tell, oh, actually, you only need full PPE for this situation, and you can have other just apron and gloves for others. And so similar to much of the rest of the country, we weren't sure how much this was based on accurate information or due to lack of PPE. But that was all starting back in February. And it took several weeks for us to have our first patient. It wasn't until I think the middle of March that anyone actually tested positive. We had one of the little hubs outside the hospital for A&E walk-in GP referral, or the 111 referrals, as well as swabbing patient in the hospital. We have one respiratory ward, and we prepared to double up and take over 2 respiratory wards. So that meant that instead of having 2 respiratory consultants working on the wards at any time, we were able to have 4 consultants on the ward, which meant that they dropped a lot of their outpatient work and some of their other service development and so on. So this is where I come in. I've been employed at the Whittington as a part-time consultant based in outpatients, and haven't been doing any of the ward work there. So thinking we were going to be hit by this wave after wave of patients that could be going on for 3 months, I thought I'd best get myself ready to be working on the wards. So got myself familiar with all the IT systems, all the access to the different wards and so on, but was never needed. We are lucky enough to have another consultant who has retired but has continued to be doing outpatient work. So she and I were able to take on a lot of the other consultants' clinics. And I think we kept our outpatient routine respiratory work going pretty much constantly throughout. We normally have registrars doing outpatients, and we lost that part of the service, but they see very small percentage of the patients due to their other commitments. So we also were given clinical support workers after a few weeks. These were the final year medical students who were enabled to work on the wards, and many of the surgical juniors were redeployed to medical roles as well. But we lost members of our team. One of our respiratory SPRs is a dual accredited ITU trainee, and so he was sent to work full-time on ITU. We had one of our registrars who was based in the community, so he was summoned back, thankfully, to give us extra support on the ward. We have one lung cancer nurse. She was seconded to ITU for 3 months. And we have 3 respiratory nurses. So one of them was seconded to ITU, another one purely for ward work. And so that left us with only one respiratory nurse to try to do many of the outpatient respiratory nurse jobs, as well as doing general respiratory nurse support to many of the hospital wards. We also have a community respiratory team, which we call the core team. And apparently they were initially told that given that a lot of community work was going to have to be suspended, that many of them would be redeployed, and apparently it was proposed that they would be doing some HCA type role. So they pointed out they had specialist skills, both nurses and physiotherapists, and 4 of the community team went to work full-time in the hospital for a few months on the wards and supporting the physiotherapy service. And at this point, I just wanted to mention our lead respiratory physiologist, Jessie Horn, who was hugely, had an enormous influence in terms of the education needed for general physios and nurses in terms of all the ventilation that was needed on the wards. And we're very proud she got a mention in the New Year's Honours recently. But she wasn't the only one. So we also have a lung physiologist, and again, lung function was almost completely suspended, but he was able to help out with considerable research and procurement and education in terms of the ventilator support needed. And I think initially we had about 4 or 5 different types of non-invasive ventilators. So obviously ITU had their own service. Normally we only run CPAP on a small area of the acute medical ward, the respiratory ward, and also on our cardiology ward. But we were needing to run it, or some form of NIV CPAP, on 2 full acute medical wards at various points, as well as medical and cardiology wards. And this is where the hospital services needed to do the oxygen monitoring in terms of the flow of oxygen and the pressure. So I'm sure some of you will remember that I think it was Watford had an alert when they couldn't supply enough oxygen around the hospital. So we had a dashboard developed just to look at the number of patients on all the different wards, making sure that no one ward was needing too much oxygen at any point. And when we were getting near those levels, the alarms were triggering. And so a lot of patient shifting had to go. In terms of the trials we participated on, it wasn't purely the respiratory team by any means. And I think actually it was very lucky that we had one of our surgeons who became our PI for the recovery trial. And we were able to, I think, enroll about 57 patients into that. That was from a report back in June. So there's still been a trickle carrying on through the summer and again this autumn since. And just in terms of those numbers, we didn't manage, I think, quite as many as North Middlesex, but they're larger in terms, and also had more COVID patients, but we managed more than the Royal Free and UCH. So we did pretty well on that. Now, obviously, they may have been enrolling patients into other trials. We also took part in the ITHRIC, which is the International Severe Acute Respiratory Trial, which is a sort of a data gathering service, and genomic trials, as well as many of our consultants, such as haematologists and other specialists, liaising with their counterparts in other hospitals. And I think the thromboembolism was one of the early things that we needed to cooperate with. So this is the Whittington admissions. The main peak was actually towards the end of March. And then these were the red line is the high probability of cases. So this is possibly slightly better clinical recognition of syndromes. But then when we look at the prevalence data, the top line is the total possible, and these are the confirmed and suspected. So this, not surprisingly, because some of the admissions are pretty long, it was the wards were pretty swamped throughout April. This only goes up to the 22nd of April. And again, just looking at the data from the recovery enrolment, we opened on site on, I think, the 27th of March, which was after a week that it had opened nationally. And we didn't enroll a patient for about 5 days. And then within a week, there are about 25 patients enrolled at our site. So that was half of the number in the first 3 months were enrolled in that first week. So ITU was turned completely into a COVID ward, and our non-COVID patients were looked after in theatres. We did have to transfer a few patients out, usually to the Royal Free or UCH. And I think we had in terms of our patient load, they were slightly older than average, but the ITU was pretty similar to the national average. So what else did we have to do apart from all the inpatient work? We had to look at the shielding criteria. So again, quite before the national guidelines came out, many of us were obviously talking to our patients and saying, this is a respiratory virus, it's similar to flu, you need to take precautions. And a lot of them were very sensible and took sensible precautions before anyone devised what shielding should be. We then had a request, could we review our chronic patients and decide who should be added? So we suffer from the fact that we don't actually keep a list of all our chronic respiratory patients. We have the ones who are admitted, who are coded, and then we have a small cohort who are under the community team or on home oxygen, and we have a small list who have severe asthma. But we don't have a list of people with moderate or severe COPD. We don't have a database of bronchiectasis or interstitial lung disease. So we use various methods. Someone had the bright idea that we could look through clinic letters, and then they discovered it was something like 70,000 in the last year, and that was unrealistic. So we did go through our pharmacology database looking for certain medications, whether it's immunosuppression or regular drugs like fluconazole or azithromycin, some types we use for bronchiectasis, for instance. We also had a large spreadsheet of patients who'd been through the lung function lab, and that was of over 1,000 patients. Now, they were coded by the possible diagnosis, but when I was going through that, the original diagnosis on the request form was very different from what was matched in clinic letters subsequently. Looking at the shielding guidelines, it was all pretty vague on the government website. More information at that point was coming through on things like mainly the British Thoracic Society, but also from colleagues in specialist centres. So for instance, for asthma, we decided pretty early on that we could use just severe asthma as a definition, similar for COPD. So we were basing that both on severe clinical syndromes as well as frequent exacerbations and the amount of regular medication, and not just on spirometry, for instance. The interstitial lung disease was one that there has still not been, I don't think, any good central guidelines. There on the charity, the Interstitial Lung Disease Foundation, and also on the British Lung Foundation, they basically said, it's really complex, it's best just to include everybody. So we know that there's an awful lot of people who have just a tiny bit of pulmonary fibrosis, particularly in their 80s or 90s, and it's not their major problem and it doesn't bother them. On the other hand, they may well have many comorbidities. So that group, we're not usually monitoring frequently, but they'll often be under their GPs for many other conditions. We never had a list of patients from GPs who were submitted. We only had a list of patients who had been coded due to hospital admissions. So that, I'm sure, we duplicated an awful lot of work. And it took about a month before we had a full list. Again, what else? We had been doing electronic advice and guidance for about a year. That demand didn't rise at all in those first few months. It only started picking up really in about July, I think. But what we did have, one of our consultants ran a COVID hotline for GPs. So again, I think the feeling she had was that GPs would have loved her to be carrying a telephone around with her so they could call her at any point, but she was seeing ward patients having to dress up in PPE frequently, and that's just not feasible. So I'm not sure how the service was found by the GPs. I'm sure some of them found it useful and some found it frustrating, but she was having 2 or 3 calls a day for, I think, quite a few weeks. We are very lucky to have a respiratory psychologist on our routine team. She was able to continue some of her routine work all online, but actually her main work was setting up a lot of psychological support for the entire hospital staff, not just our team. So she was working with a team, and it started off at sort of low grade moral support, things like just having a comfortable area in the staff canteen, which was also helped by Operation Wingman, where the airline supplied some staff. But it moved up to a bit of peer counselling, and then people who requested could have an assessment or talk to a counsellor, and some were referred to psychiatry as well. So she's been also then running some reflective practice sessions with the different groups. So these were more about a month or 2 after the main work had been, and very helpful for teams to discuss what they'd been through as a team, the difficulties and the emotional stress that they'd had to be through. And again, she also did some online or some more creative work, which has been going on and available for display. We have, I think most of last year, we were having a high turnover of our administrators, and we didn't have any permanent appointment from about last October. So we were having different secretaries every 2 or 3 months. A lot of the time they were working off site with their own difficulties in trying to connect, and they weren't familiar with our service. So again, that just put an additional extra difficulties onto the staff. And many of us were having problems trying to work remotely from home as much as possible. And I'll come a little bit more onto what we were using in outpatients later. And then in the summer, when we were hoping to have a little bit of a step off the gas, we had to go through the getting it right first time. We had 2 of these huge reviews of our work, one for general respiratory and one for the lung cancer service. So again, huge amounts of work needed when people were trying to sort of regain their energy for the upcoming winter problems. So this is a photo of what our respiratory clinic reception looks like. Going back to the hospital staff, I can remember talking one day about mid-April to one of my consultant colleagues, asking her how she was. And she said, yes, it's hard work, it's emotionally draining, it's hard supporting the team, but I'm coping. And then in contrast, talking to a nurse the same day, the respiratory nurse who'd been visiting wards, and she was saying it's terrible. When she goes to talk to the nurses on the wards about their patients, she's often picking up the stress levels running really high. And again, I think this kind of reflects the levels of knowledge and autonomy, and how that is reflected by different people in stress at work. And so coming down to our clinic receptionists, they were barely seeing any patients. It was only very occasional people were coming in, but they were frightened. They were really worried that the staff working on the wards were coming through the clinic area and could be bringing COVID from the ward into the reception and infecting them. So not only did we have some tape on the ground to show what the 2-meter distance was, they moved all the clinic chairs to barricade themselves to make sure no one could come near them. And you can see one solitary chair is if a patient needs to wait in the waiting room. The situation has changed now. They've got a nice Perspex screen. They've removed all these chairs. So it looks different in terms of it's more open. But I think actually some of the non-clinical staff really found this early phase quite frightening. By now, we were suffering from information overload. We were trying all to learn as much as possible. So an awful lot going on networking within the hospital team on WhatsApp groups, staff rounds when they could be restarted. We were also getting information from many different specialist societies. So these are just a few. Sorry. The London Respiratory Network was a group put together of respiratory consultants who were meeting weekly and sharing knowledge, both in terms about managing patients, but also the difficulties in terms of ventilating, whether with CPAP or NIV machines, high flow oxygen, all these issues. And then subsequent moving on to look at discharge and follow up. The British Thoracic Society published an awful lot and was helpful. The Association of Respiratory Physiologists also provided a lot of guidelines in terms of what was safe, and many other databases. And I think I counted up just by April, after a month or 2 months, we had 80 different papers and protocols that we could look, which is impossible to go through. And they were obviously added to more and more, plus all the specialist journals that we should be reading. So we became relative experts in what we thought we knew enough about in terms of ventilators. So early on, I think we had about four or five different either ventilators which were being used as non-invasive ventilators, and they were being used by staff who weren't familiar. So medical consultants and juniors and medical nurses were having to deal with this. So Jessie and physios and a couple of my colleagues were helping and educating the other teams. Again, the Royal Free were able to install a new oxygen tank to increase their supply. We looked into this and were told we don't have the pipe work. So we could have as much oxygen as possible coming in, but we weren't able to supply it around the hospital. So that is something that apparently is being looked at for the winter. I don't know if they've actually made any decisions or any plans for that. So one particular problem for respiratory wards is the aerosol generating procedures. So this is classed as a high risk activity for medical staff. So certainly not just within respiratory, but for ITU particularly, vent people who need intubation, that's a AGP, people performing endoscopies, not just bronchoscopies. And if you're in a room with a patient receiving a nebulized drug or on certain types, so high flow oxygen and CPAP compared to certain types of NIV. But lung function was deemed by Public Health England not to be an AGP. So we were being told, yes, it's safe to do just with an apron and a simple mask, not with full PPE. Now, many physiologists and respiratory consultants felt very unhappy with this. And we were obviously, so I think PHE gave the guidance that it wasn't to be considered, but you could use your own local discretion. So I think many hospitals around London or the country are regarding it as a high risk procedure. We became expert at what rooms need in terms of the air changes per hour. So could we start to see patients in a side room for clinic? Could we start to do it for bronchoscopy or for lung function? And it was deemed, I think, if you've only got 6 room changes per hour, then you have to wait an hour between patients and then 15 minutes to clean the surfaces. So our lung function lab has got an extraction unit. So we've got 10 air changes per hour, so we can have only half an hour waiting before you need to go in and do the cleaning and then allow another patient in. And this is to do with some of these procedures having an increased risk of infection due to all these measures, the droplet deposition or the aerosol dissipation. So by I think the end of April, we all needed a bit of light relief, and thankfully along came Trump and suggested injecting ourselves with bleach or Dettol, and someone said, well, how about using it as inhaled medication? And unfortunately that never made it to trials, probably quite safely. But I was trying to keep an eye on what else might be relevant, and just looking back, these were some of the issues that we were aware of that reached the general media as well as medical media. Quite early on, people were looking at smoking and would the effects of lockdown increase the stress and increase the smoking rates, or would the message get out that people were more prone to develop severe COVID and maybe this was a good time to do a health check and stop smoking? So ASH in June published a review which had been done through UCL saying up to 1 million people had quit or attempting to quit due to COVID. And this was, I think, based on internet surveys and some telephone calls. But there have been multiple other studies based on, usually on online questionnaires or even telephone. And then there are a number of different smoking cessation or quit apps. So they were looking at how many app downloads had been, how often the apps were downloaded. This isn't just this country, it's different apps across Europe and America as well, and China. And I think basically the jury is out. More people seemed to take up smoking. A lot of people did quit, and we haven't got enough data to say conclusively what the overall effect was, and out of those who've quit, how many have managed to stay non-smokers. But there was a review in October in this journal which looks at quite a few of these studies and goes through them. And then again, in April, there was a report from the Pasteur Institute saying very few patients who are smokers, sorry, very few people who smoke had been admitted with COVID. So this was looking at their institute and looking at the people with COVID, and found much lower rates of smokers than expected. And they were hypothesizing that nicotine might actually be protective. And again, from many other studies now, some have shown a slight decrease, but I think more have shown it's not actually a valid finding, that some, and that certainly the rates of severe COVID pneumonia or other complications are higher in smokers. So I think part of the postulate or the hypothesis was based on the fact that nicotine can block the ACE2 receptor. So if it's blocking the receptor, which is one of the entry points of the SARS-CoV virus into the cells, this may be why it's protective. But then some other cell work has shown actually smoking may upregulate the ACE2 receptor, and it's providing a port of entry, and the receptor is particularly found within the bronchial epithelium. So this is why people may be more at risk. So obviously a lot more basic lab work as well as larger scale studies will be helpful. But again, a great review from the Oxford Centre for Evidence-Based Medicine, although that is now a few months old. Something else that we often go on about in respiratory medicine is vitamin D, and how low levels are predispose people to have more severe respiratory conditions. So it's often measured in people with COPD and asthma. If we say, oh, yeah, you've got a low vitamin D level, we'd better supplement it, and that might improve your overall airways control. So even before this year, we still don't really have conclusive evidence. I think have been studies showing that if you have respiratory conditions, usually airways disease, but also respiratory infections such as pneumonia, you're more likely to have severe illness if your vitamin D is low. It's not certain whether you're more likely to have the illness because the vitamin D is low, or whether it's an association, and if you are more likely to suffer from respiratory illness, then that could be why, or one of the reasons it's causing a low level. What's never really, I think, been shown is that by supplementing vitamin D, that we improve the outlook. So those supplements don't show better control of asthma, and I don't think they've shown reduced severity of pneumonia. But there is now a study, I think Martin Landry's enrolling people into taking vitamin D supplements and seeing what's going to happen there. Again, inhaled steroids, we use them obviously in asthma, and the message obviously is to try and make sure people continue to take it if needed to protect their respiratory airways, reduce their hypersensitivity. But with COPD, it's a lot more debatable. It's certainly been shown that inhaled steroids predispose people to have infective exacerbations. However, for people with severe COPD, we do now recommend inhaled steroids in the form of triple therapy, along with long-acting bronchodilators or muscarinic antagonists. So early on, there was a lot of research saying, certainly take your steroids if you're asthmatic, but it's best not to have oral steroids. There was the worry about steroids impairing the immune response. But since the dexamethasone and then hydrocortisone have been shown to be effective in treating COVID, I think people have been a lot more reassured. And also now looking at whether for people with lung disease, having a regular inhaled steroid dose is actually proving some protective benefit. And again, we're going to need a lot more data gathering before we can really say. So respiratory physicians are also interested in flu vaccination, both for hospital staff, but also for our wider patient load. So we had our hospital vaccination staff drive starting in September, and due to a medical round happening the week before, it was offered to all medical staff coming along, and the queue continued throughout, and they had to get extra supplies of the flu vaccine. So staff uptake has been particularly high this year in our hospital, and this 50% of staff have had it within 6 weeks. I'm not actually sure that's true, but it's one number that I have heard. Certainly much higher numbers than usual. We've also been able to offer it opportunistically in our outpatients clinics. So whenever people are coming to face now for any clinic, we are able to offer them flu vaccination, send them down to pharmacy, and they can have it there and then. The first patient I tried this with, unfortunately, the pharmacy didn't have enough supplies and he was told to make an appointment for the following week, but it's there as an additional benefit. Certainly what I found throughout this autumn, I normally start asking patients August or September, make sure you have your vaccination, have you got any questions about it? Usually a fair proportion have questions or will tell me I don't want it, I've had problems before, I don't intend to have it. This year, I think almost universally, I've only really had one or two people say they're not having it. Most have had it already or booked the appointment with their GP or had been able to have it at a pharmacy, which is great news. And actually, I don't know if anyone knows about the situation in Scotland. All I've been able to hear is they've changed their system, and certainly in Glasgow, people are not able to have it at their GPs or at a pharmacy. They're being summoned to local clinics and they're being summoned by aid group or patient group. And some people are still waiting to have it. Whether this is going to be the system that we're using for any COVID vaccine, I don't know. It may be that now Scotland's been through that system, they'll be better equipped to deliver a COVID vaccine. Maybe in England, if we're going to do it, we'll be able to be a little bit more efficient. It all depends on when we can get the vaccine anyway. But it's certainly going to be a huge amount of work for GPs if they're asked. So also, one small reason of hope is that the flu season this winter may not be as severe as previous. It's still speculative, but there's a system called FluNet, which monitors the flu seasons around the world. And in September, the CDC put out some data looking at Australia, Chile, and South Africa, and what their flu season had been. And generally, the Northern Hemisphere tracks what's happened in the Southern Hemisphere. So these are 3 different countries. The dotted lines are what's happened previously. Just to make it slightly clearer, looking at Australia, the bars are the number of tests for seasonal flu. The dotted and dashed lines are what's happened in the last 3 years, so slightly different patterns. But this heavy blue line at the bottom is what happened this year. So, sorry about that. Week 14, so about April to June, very, very few cases of seasonal flu in Australia. And that was similar on the previous slide, looking also at Chile and South Africa. So this shows, this is when Australia locked down. This was hospital quarantine. Whether those effects these years really did lower the risk of seasonal flu in Australia and similarly in other Southern Hemisphere countries, whether it's a different strain, it's all speculative, but there's a small ray of hope. Whether we'll see it in the Northern Hemisphere, I don't know. So just a little bit about what happened with our chronic respiratory patients. Don't know I have time to go into these cases, but I just thought I'd mention a few that stick in my mind. So this first patient, LB, has got interstitial lung disease. I've been monitoring him every 3 to 6 months over the last year and a half. So I spoke with him in April, again, telephone clinic, not in person. He hadn't had any lung function. He was doing well. He was still going on his daily walks over Hampstead Heath, possibly a little bit more breathless than 6 months or a year ago, hard to know. And this is one of the difficulties we've had. Most people aren't as active as him. And certainly for the people who've been staying at home, it's very difficult to get a measure of what their breathlessness has been. He eventually, so because he had got definite fibrosis, and on the previous clinic visit, he had had a slight reduction in his spirometry. So I was awaiting for formal lung function testing. But because of what he told me, I actually referred him to the specialist ILD team who are down at UCH. And we do that because they are our local service for providing, prescribing some of the fibrinolytic drugs that we can't prescribe at the Whittington. So his lung function at the Whittington had been delayed. He should have been having it in April. The service was suspended completely for 3 months. So he actually got his lung function and his review at UCH at about the same month. And actually his lung function had held up. he doesn't meet criteria for treatment. He's doing very well from a respiratory point of view. He's actually unfortunately had a coronary event, but that's been treated successfully. They had a good review. He's coming back to me. I've spoken to him and he's doing well, and hopefully he'll continue under our care without needing treatment for his interstitial lung disease. The next patient, SN, is a lady who presented to our ambulatory care unit in February. She's got severe COPD. She'd not actually been seen at our hospital before. She was diagnosed at, I think, North Middlesex about 10 years ago, and she's done very well. She'd had a little bit of inpatient care, community care over the first couple of years, but hadn't seen any hospital services for about 8 or 9 years, managed purely by her GP, despite having an FEV1 below 30%. She came in actually with frightening breathlessness, also had symptoms most likely of a TIA. She was offered admission, but she declined. This was all before COVID. It wasn't because of that reason. She just did not want to be in hospital. So she was referred to our outpatients. And before she was seen, she'd had a CT that showed she'd got a nodule in her lungs. We were able, I think, to get some imaging from before. It looked suspicious. And we thought this was a nodule that we needed to be doing a PET, which she had. And then we had a long debate in our cancer MDT about biopsying, because we knew she was frail, but this was a lesion that, if it were cancer, was still small enough to be treated by radiation therapy. And someone who, people can manage that without needing to be have particularly high performance status. So she'd met my registrar, not me. So I phoned her and discovered that she wasn't at home. She was staying with her daughter, who said, could you try my sister tomorrow? That's the daughter she was staying with. So I phoned the next day and discovered that the lady had gone to stay with her daughter in Ireland, and that this is something she'd been thinking about. She was aware her COPD was progressing. She wasn't managing by herself. And the decision had been made between her and her 2 daughters that it would probably be best. So me telling her that she might have a cancer, which she'd known before having a PET, would like to do a biopsy and consider treatment. And this was in, I think, March. It was very difficult for them at the time to decide what was best. So we kept the situation open. Given that the MDT had been quite cautious about recommending it anyway, it's quite possibly a slow growing nodule. It may not actually cause her problems. I think she made the right decision. She stayed in Ireland. She was able to register and transfer a lot of her information to a respiratory, well, initially to the GP, to be referred to the local services over there. The next lady, again, she was referred to respiratory outpatients with what seemed to be bronchiectasis. So she went to have a CT scan, which indeed confirmed that. However, it also showed some abnormal suspicious bone lesions, looking possibly like bone secondaries, but no obvious lung primary. So again, we referred her in March to the Cancer of Unknown Primary Clinic, the breast clinic, and for various bone scans and other tests, at which point services were suspended. Some of her tests would have taken place, could be booked because they were suspected cancer. She at that point said, I don't want to come to hospital. So for a couple of weeks, we were phoning her every couple of weeks to see how she was feeling about it, trying to reassure her that outpatient investigations were relatively safe. We could never guarantee it, but we thought it was a safe thing to do. We were worried she might have an underlying cancer. And she said, no, I'm feeling fine. I don't want to come to hospital. And in August, she said she felt safe enough to come to hospital. She was still feeling fine. She doesn't have cancer. She made the right decision. One patient who caused a few more problems is this final lady GP who has sarcoid. And she's been someone who's not been managing well over the last couple of years. She's needed quite heavy duty prednisolone at the beginning or towards the end of last year. She'd started on azathioprine, which seems to be controlled, but on weaning the prednisolone, things had flared, so I was increasing the azathioprine. She has added complications in that she works in Jersey. She works over there 3 weeks at a time and then comes back to London for 1 week each month. She works in the health service as a mental health nurse. And she was over there when they went into lockdown. And although she's been there for a couple of years, she's only on short-term contracts and was told, your contract is finished. We don't want to employ you anymore. Get out of the hospital accommodation. And luckily, she was able to register with a GP who helped her, and she was able to stay in the accommodation throughout until she was able, after a few months, to move back. She registered as a temporary patient. The GP was able to take over her prescribing and organise blood tests. What I hadn't realised in Jersey, that she was ending up paying for the medical services in terms of every blood test and appointments that were needed. And she, again, she's of African origin, overweight due to steroids, so quite a high risk. So she was easy to manage because she's very sensible, but obviously quite significant anxieties and social situations made her life difficult. And she's now come back, and again, due to difficulties maintaining her, she's been fed into the UCH interstitial lung disease clinic and is managing relatively well. Her lung function, which we weren't able to monitor for several months, has been holding up. So there's been a few patients who've been particularly interesting or difficult to manage along the lines. But the bulk of our work are with COPD patients. So this is just some data looking at patients admitted this year and last year where the primary diagnosis is COPD. So this does exclude anyone who came in and was coded as having a lung infection, whether pneumonia, viral, whatever, and COPD is a secondary. So this is not likely to be the whole thing, but the blue lines are 2019 and the orange lines are numbers admitted this year. We don't know why. We don't know whether the people have been too frightened to come in or whether they just shielded better and that reduced their risk of all types of exacerbations. But it's certainly interesting as a starting point. So talking to our two physiotherapists who are lead in the community team, these are the column on the left is just the same numbers. Their feeling has been that they have not seen excess deaths in the cohort they manage. They initially had fewer calls. People were calling GPs or networks and not actually calling the core team. Although the core team of nurses and physios were able to call them all individually and offer some telephone support and some actual home visiting, but at much lower rates than normal. They found now, looking back, that many more managed exacerbations themselves with GP support, but they ended up having far more courses of steroids and antibiotics than they would do normally. And I'm sure a lot of that is due to the difficulties GPs have had with remote monitoring. And it's often feels safer to give a prescription when you're not able to perform any face-to-face clinical review. It's harder to reassure patients, even when you don't think a prescription is necessary. It's much harder over a telephone to actually convince patients that they don't need it. But what Anthony was able to say is actually their main trigger has been breathlessness, which is relatively common. And we try normally to educate patients that just because you're more breathless doesn't mean you're developing an exacerbation. But their anxiety levels, their education or the GP confidence in treating has meant that they've probably had less optimal treatment this year, which is now meaning that many more of them think that steroids or antibiotics are again the treatment that they should be having for exacerbations. So the team are trying to again re-educate them in terms of what actually an exacerbation is, how to manage breathlessness, how to manage their COPD. One good thing that came out in April was many of our patients said, we're noticing that the pollution levels are much lower than normal, and it's much easier if I stand in my garden or walk around the block. My breathing's not as bad as normal. But far more of them sheltered at home, didn't go out as much, didn't go for a daily walk at all. And they had a lot of muscular deconditioning. Several people have hardly left their house for several months at a time. And this all feeds negatively into a cycle of spiraling poor COPD management. So we'll see what happens to this group. So what has been improved? I think certainly on the wards, we're using a lot more iPads or smart communication for relatives and patients. And this has got the benefit of people who don't always have relatives who live in London. And that's hopefully something that will continue. The London Respiratory Network, which was having weekly meetings, shared huge amounts of information, was very supportive and useful both in terms of treatments at the time, looking at what we're all doing in terms of treatment for COVID, AGPs, routine work, and how to develop post-COVID clinics. Although the frequency of meetings was stepped down over the summer, and currently has been stopped, not really sure why. The main difference to our clinic working has been doing telephone and videos. So our hospital had been bringing in video clinics beforehand, and it was being trialed at the beginning of this year, only in certain specialties, using a system called Attend Anywhere. It's not been something that we had been using in the respiratory service, and actually we've been quite slow to take it on. So none of us are doing routine video clinics. A lot of this is due to not having it installed on all the office computers. We've got many different clinic areas, and it was initially being only brought in certain clinic areas. Most of our hospital computers are old and don't have any microphone or camera. So we've needed to buy additional hardware, and there's been a long waiting list because many people across the country are also requiring these things. All of our clinics, apart from a few cancer clinics, were virtual by being telephone right from the middle of March. Since September, our department, and again across most medical specialties, are aiming to do 50% of patient reviews on site and 50% telephone or video. Our physiotherapists who run sputum clearance clinics are not doing clinics in person because they can't teach this in one small room, but they are able to offer video clinics to patients who can manage. A lot of our patients can't manage video clinics. It's relatively simple software. You're sent a link via email, and you just click on the link and you're held in a virtual clinic waiting room, so you can see if you're first in line, second in line, what the wait's likely to be. You can carry on working at your desk, doing whatever, and then you just get called and join in. So it's great if you're tech familiar and you're working at your office or working at your home. You can carry on working instead of having to be sitting in a hospital waiting room, but it's not ideal for many of our patients. One of the reasons we were quite slow to volunteer earlier in the year is that we were already running telephone clinics to feedback results, and video reviews don't offer huge amounts over telephone reviews. A lot of our reviews we want to be doing face-to-face in person. We're still benefiting from watching people walk into our clinic rooms, but mainly we like them on site so we can measure their saturation, measure a quick spirometry, and quite often do a chest x-ray as well. So we will be doing some telephone video calls, but we're still going to be needing to do an awful lot in person. What we have been doing is giving more patients oxygen saturation monitors and educating them how to use them, partly for COVID patients, but mainly for our chronic respiratory patients. And then some hospitals like Northwick Park, I think, has taken on a virtual ward, which again, some ambulatory wards have used similar systems in the past, but this has been some software that was offered and spread. Again, the London Respiratory Network was quite informative about this, trying to manage patients virtually and be able to do some home monitoring and reach out to patients as well. Electronic noting is one of these ongoing things within many different hospitals and GP practices, which some hospitals and GPs do much better. Our hospital, I think, is relatively slow. We're getting better. It's been a big push to try and get us to improve our hospital notes and communication between hospitals and GPs much better, but we're still way behind where we'd like to be. Something that our hospital has been focusing on, not just during COVID, but this again has brought this much more widespread attention, is looking at homelessness. We're all aware that particularly in London, homelessness is almost counted as a comorbidity, but definitely as a risk factor. So it's something that one of our consultants had been auditing over the last year anyway, looking at the prevalence of homelessness amongst our medical patients. So we had data from July last year and then January this year showing about 7 or 8% of all adult patients were either registered, well, either homeless or at risk of losing their home or living in unstable situations. Interestingly, and really good news, during the COVID months, we had very few patients admitted who reported being homeless. During their admission, some of them became homeless. And it's certainly something that the local councils were hugely instrumental about trying to find accommodation for large numbers of people who wouldn't normally qualify. So data from Haringey, I think they rehoused about upwards of 500 people, when out of that group, about 25 people would normally qualify for some kind of hostel or home. And whether this in itself has been able to reduce the numbers seeking hospital beds and treatment it's a bit early to say, but what they were setting up is not just giving them rooms, they were providing them with a GP service, with a virtual clinic once a week. They were also providing substance abuse support, smoking cessation support. They also were able to help them access blood screening for viruses such as HIV and hepatitis, but also COVID swabs, and providing them with a housing officer. So if this is something that can be taken on by London councils, this will definitely reduce the burden of patients needing hospitalisation for a wide variety of conditions. And obviously by providing them with stable accommodation, they're able to access chronic care for a variety of medical conditions, and hopefully won't need to come in due to problems in future, not so frequently. But not surprisingly, there have been a lot of difficulties. The technology, we don't have enough of it, or it took us several months to acquire the technology. People felt very unconfident in using it, have needed training. The clinic space and the PPE has been a significant problem. We've got a clinic area which has got about 5 clinic rooms. It's also the access to the lung function, echo, ECG, neurophysiology rooms. And we were told for several months pretty much to have it shut. So when we've been trying to see cancer patients, we've been moved to other areas, but have to book rooms. And at one point we were being told you need to book rooms 6 weeks in advance, which we can't do for people on the cancer pathway. And again, if you see someone or you speak to someone in a telephone clinic and they're not doing well and you want to bring them in for an assessment, you want to bring them in within a week, not wait 6 weeks before we can book a clinic room. So that's been an ongoing battle with management. And I think certainly in the first few months of the year, it felt that clinicians were driving the change in the treatment. And since the summer, the management have been, again, trying to put the brakes on and trying to control things, not always how we would like. We've been having to use PPE in clinic areas and investigations. The main problem is the delays to investigations. So looking at our lung function room, we would normally be seeing, I think, upwards of 20 to 30 patients a week for lung function testing. They are also the staff who set patients up on sleep studies. So the person will come in, be shown how to use the sleep monitor, take it home, bring it back the next day and help the analysis. And also they run the reviews for people who are on CPAP. Our patients who are on NIV are seen at the Royal Free. Due to the reduction in numbers that they can see, we're now down to about 15 patients a week having any type of lung function. If we only do spirometry and diffusion, they can get that in about half an hour. If we're asking for bronchodilation or static lung volumes, that takes about an hour. And at the moment, we're needing 45 minutes between patients. That also means that if we see a patient for lung function, we can't then see a patient to set them up on a sleep study. So that we do have access some days to see them in other rooms, but in general, we're having significant reductions in the patients that we're able to see. So when we brought our service back on in about September, I think we had a backlog of about 200 patients waiting to be seen. On average, we refer about 15 patients a week, and we're only able to see about 15 patients a week. So that backlog is not getting any smaller. And as yet, we don't have any plans to be outsourcing it to private. We are seeing people at the weekend already. So that's hampered a lot of our monitoring of patients. And like many other respiratory specialists in other hospitals, we feel that many of our patients have suffered. Telephone review and a chat is lovely, but if you can't monitor their lung function adequately, then you miss out on a lot. CTs, we haven't had such a hold up. There were many that were cancelled in April, but we were able to get them if we needed them for outpatients. And since then, we haven't really had too much of a delay. The mask exemption, again, is something that, as a respiratory doctor, we're asked quite frequently from patients, and we tend to keep quiet and not suggest it. Looking on the government website, patients can log on and they can print off their own exemption form. And again, Asthma UK has an exemption form. People can make their own. There are no clear guidelines as to who qualifies for a mask. I think most of us feel that people should be wearing masks. Anyone is able to breathe adequately through them. We're able to oxygenate ourselves. People who have pneumonia can wear a mask and still receive adequate oxygenation unless they're needing supplemental oxygen anyway. However, we know that people with COPD and who have chronic hypoxia, often when they're feeling breathless, we say take a fan and hold it to your face, and the movement of air over the face relieves the breathlessness. People know this, they open the window and stand by an open window to get fresh air, and by having that sensation of air moving over their face, it relieves breathlessness. So not surprisingly, wearing a mask reduces that sensation and makes people feel more breathless. I have on occasion, I haven't been able to because I haven't seen many, but I have had people sitting in my clinic room with a saturation monitor and a mask on saying, look, your oxygen level is fine, keep the mask on, just breathe calmly, keep your oxygen, and they still feel breathless. And some of them, obviously it's an anxiety or it's a discomfort over and above the discomfort that many of us feel from wearing masks. So there's a lot of reassurance trying to promote behavioural change without being too sort of finger wagging, but if people want to have an exemption, they are able to provide their own without needing us to do it. Post-COVID care. I'm sorry, I'm just realising the time. There is still no clear definition of long COVID, chronic COVID, but I think the NHR produced something showing there's different syndromes going on. A lot of people who have a severe viral illness are fatigued for some weeks afterwards. People who are on ITU have often a critical care neuropathy, which can carry on. And with COVID, we're seeing end organ damage in the lungs and in the heart and other places. But I think much of the problem in the COVID clinics is this chronic fatigue-like syndrome when people are having cyclical multi-organ symptoms. There's Your COVID Recovery website, which has got a lot of useful information, but does not feed people into therapies because we don't have the access at the moment. We also have another COVID hub, which has got information, but we don't have enough resources to be setting up clinics at the moment. This would be my ideal COVID clinic. The NHS England actually provided some guidance over the weekend, which looks remarkably similar. We'd like to have access to huge amounts that we don't. So my colleague, Dr. Dharma, has set up a COVID clinic. She has a chest x-ray and a physiotherapist review, along with breathlessness and psychological scores. The physiotherapist runs the exercise testing. So rather than doing spirometry, you ask patients to sit and stand repeatedly in a minute. And if you can manage 16 reps or more, it's a valid test. For people who have arthritis or chronic pain, if you can manage to do 40 steps walking down the corridor, then that's again an alternative, and monitoring their oxygen saturation. And then that's followed the next day after MDT discussion by a doctor review. Some of them then get fed into other investigations and some are discharged. And so these are just some of the numbers from the first 160, sorry, about a half of them were from the wards and half were referred from GPs or the ambulatory care. Again, just over half had abnormalities when they were ill with COVID. A few of them had been on CPAP or ITU, but many not. And then Heitman works between the Whittington UCH, and she's been overseeing the case down there, so she kindly forwarded me some of this data. They've been able to have far more encounters. They've got slightly larger resources. They were running spirometry in, not a lorry, but in the car park in one of the vans initially, and some patients have been able to have cardiopulmonary exercise testing as well. They're preferring to use a 6-minute walk if possible. And she has an interest in interstitial lung disease already. So this is just some of her data. 700 discharged and about 500 were accepted phone calls or reviews. And out of that cohort, 80 patients had post-COVID lung disease at 6 weeks or 12 weeks. So many of them have significant interstitial disease during the admission, but a significant proportion are having ongoing change. Now, out of this cohort, they weren't the ones receiving dexamethasone during their admission. Some of them did receive high-dose steroids, not all of them. Some of them had it prescribed at outpatients afterwards and showing some success. And again, just a quick group of symptoms that people present with. These are all mainly related to breathlessness, chest pain, and many, many other organs and symptoms are found as well. And the Leicester group are running a national study involving over 200 hospitals, trying to gather thousands of patients and monitor their post-COVID illness. So both UCH and Whittington are contributing patients to tier 1, and some will be recruited into more investigations and testing. So really, that was just a very quick run through. Sorry, I hope there's still a bit of time for questions if people would like.
Hello. Thank you very much. We've collected quite a few questions along the way. If I can just start off with one, was when you were then referring to some of the patients had been on ventilators and some patients had been had been managed without ventilators. Is there any difference between those two cohorts of patients when they're coming through the system? And the other,
we don't have enough data, I think, to be able to distinguish. Yeah. Some of the ones who were invasively ventilated have initially been followed up in ITU clinics as well. The general feeling seems to be that the patients who had more severe lung disease often do make good recoveries and are not developing this cyclical fatigue, but they have the other problem. So some of them are having ongoing lung involvement, which seems to be responding to steroids in many. And this is where there's quite good research tying in with post-MERS and post-SARS, as well as other flu pneumonitis.
Right. So the severity of the disease doesn't correlate with the
It doesn't seem to be.
Yeah.
But I think this is where the PHOSP study will be able to gather a lot of data.
How much of the fatigue is actually related to breathlessness that
not always. I've got one patient who I've been following, and I think fatigue and brain fog, dizziness, concentration problems, more of a problem for her. She does have days when she is breathless, and on the days that she's been trying to exercise more because she's been feeling better, that often sets her back, and it's the fatigue that's more of a problem. And that's quite common in other patients as well.
And the question of steroids, is which you've raised. Is steroids in mild disease in the patients who you kind of selecting to go into the more advanced or more complicated care? Is there any role for steroids at that level?
Not in mild disease at the moment. So we're still giving it in hospital as developed from the recovery and the other trials looking at hydrocortisone. So basically people who need oxygen are getting steroids during the acute phase. But since those trials, well, the recovery wasn't recruiting community patients, but in hospital patients who didn't need oxygen, there was no benefit. So I think that's still the way to go, but that's maybe dampening down the respiratory side, whether it's dampening down the whole systemic inflammatory response, whether oral steroids would actually prevent long COVID in a cohort, I don't know.
Yeah, but it's an interesting question because from the patients that you are seeing, are they having fibrosis at other sites? Is there any evidence of any fibrosis at other sites that's happening?
That's where we don't have an integrated COVID clinic, so we are sharing people. Yes. And some, I think, having a lot of GI problems and some cardiomyopathies, but I'm not sure whether it's found in the same patients or in different patients. And
there was a recent review of the cardiac complications of the flu. Presumably you normally see some cardiac complications of flu every year. Doesn't that happen?
Yes. I'm just trying to think back. It's not been something that I think I've noticed a lot in the past. It's possible because people with flu end up on a variety of medical wards, and it tends to be, if you've got underlying lung disease, that you end up on a respiratory ward, and it may be that those who develop cardiac complications aren't actually under respiratory doctors. So yes, it does happen, but not in large amounts. I don't think.
Do you think, moving to the question of consultation, what about how much harm do you think we're doing by switching to telephone consultation?
I think a lot.
A lot.
I'm not going to talk about primary care. I mean, actually, I've been through e-consult with a GP, which is great. But I think certainly respiratory colleagues in other hospitals as well, we worry that we are not assessing our chronic patients adequately, and we're not always able to assess new referrals adequately. Quite often now, sorry, my son's dancing in the background.
Yes.
We do an initial telephone review, organize some investigations, and then see people with the results of the investigations, or we see them initially and then follow up with a telephone call. But it's very difficult to make a good judgment by phone of how frail a patient is, all sorts of things. And it's very difficult to build up the trust and the communication by telephone.
There is a question about end-of-life care.
Yeah.
Two aspects of end-of-life care. One is obviously the COVID-19 hospital end-of-life care, where you must have encountered those patients, and the other is the cases that you mentioned. The question of end-of-life care must have arisen for them. And what about the use of opioids for end-of-life care? Has it been affected by this? So the two.
Our hospital palliative care consultant was involved very early on in hospital planning. They also fed into a network for ethics for decisions on managing hospital inpatients, and certainly breathlessness management and pain relief was built into guidelines. It was available for the hospital staff. We did discharge some people whom, if the treatment escalation plan said we're not going to transfer you to ITU, for a few people we were able to say we'll discharge you, and with an expected palliative outcome. And I don't think, from a few cases that I've heard about, I don't think the community services were in place at the time. For instance, there's one patient I knew that went from our ward who went back home, and it was assumed because he'd developed COVID whilst at home that his wife was likely to have been a contact, may well have caught it. And so she wasn't given clear instructions on what barriers PPE to be using in terms of nursing him, even though she had nursing support coming in to look after him. And then she came in 2 or 3 weeks later with COVID. So, having lost her husband recently, so there are just a few stories like that, and talking to GPs, friends, about the difficulties they were having looking after people, either with chronic illness or elderly people, when one person had it and one didn't, and just the lack of community care at the time was very, very difficult. So I think there have been guidelines, and it's just not always been possible to get that in place.
So in other words, it's another example of where the care, the normal care structure has not really coped with.
I don't think so, whether it was at home or nursing homes. No.
For the second wave, has that been
I don't know.
being addressed?
I don't know.
It's a difficult
Yes.
question. In your document, in your patient list, in the numbers of patients and so on, that the fall in numbers of patients and numbers of admissions, is that fear?
Well, we thought it might be, but this was a particular, the numbers admitted with COPD, very few of them are under our core team, but the cohort that is under the core team are the ones who have severe COPD, and we didn't see excess deaths in that group. So it's reassuring. Whether there have been excess deaths in the community due to COPD and those patients should have been admitted, that we don't necessarily have the data from, and that might emerge. Yes, I think a lot of people have been very frightened about coming to hospital.
Right. And with regard to the redeployment, do you think the redeployment was a success of not necessarily in your case?
In certain areas. So there's no question that ITU and the wards needed more staff, and it was better that they had some trained, experienced staff. So the respiratory nurse who went to work on ITU, she already had an ITU background. So better that they were able to use her rather than to have someone who'd been working in outpatients and hadn't been on the wards for weeks or years. So I think a lot of our chronic and outpatient care suffered, but on the other hand, that was due to other things that we've already discussed. I think we provided what we could, and it wasn't always due to lack of staff. It was due to difficulty obtaining rooms, difficulty getting investigations and that kind of care. Having said that, we're not planning to redeploy so many staff again for this winter.
Right, because that's one of the...
That's one of the issues, but then we're also trying to keep, I think, non-COVID work going at a better level, not just our specialty. But I think hospitals in general in London are trying to keep the non-COVID outpatients, investigations and so on.
And you think with some success, is that
too
early to judge?
Too early to judge in terms of the COVID, if COVID surges again during admissions. So at the Whittington, the last few weeks had a trickle of patients coming back. We're usually over the last couple of weeks just still been in single figures or just going up to about 12. But I think Northwick Park, or certainly North Middlesex, they've had much bigger numbers. I think North Middlesex had about 60 or 70 patients in last week. So we could be following.
Right.
And so we're supposed to be COVID light. We don't know how that works. We've only allowing 2 or 3 people on ITU. We're supposed to be shipping people to the Royal Free and UCH, but we don't seem to have a clear plan. Is it just when they're really sick, or is it at the beginning? It's not at the beginning because we're keeping them on the wards at the moment.
So you are keeping them on the wards with other patients?
Segregating them, yes. Side rooms when possible, if necessary, moving to a COVID bay again, and having green and red wards.
Well, I think we've exploited your knowledge of this field, and just want to say thank you very much for giving us this insights into what's actually happening.
You're very welcome.
Very difficult circumstances. Thank you.
Thank you very much. Bye.